This video is going to cover ulnar neuropathies and ulnar neuritis and irritated ulnar nerve down into the fingers for throwing athletes and anyone having these symptoms. Max Wardell, overheadathletics.com. I wanted to talk about ulnar nerve flossing or nerve flossing, which is a gliding of the nerve back and forth. Some things to consider prior to going into ulnar nerve flossing or any nerve flossing technique. And kind of things that as a clinician we'd be thinking about in terms of what's causing this resultant ulnar nerve distribution symptomology. So essentially, whenever we have ulnar nerve issues, we're going to feel maybe a tingling, pain in the elbow, shooting down into these last two fingers, the ring finger and the pinky finger, and the side of the hand here. And we have to consider a few things that could be going on. You may actually have a true ulnar neuropathy that's a result of the nerve coming out of the little groove here because the nerve sits in this groove and it could be bouncing over. Or you might have tension problems where tensioning the nerve is bothering you. And if you're a throwing athlete, it might be something that you're doing in the way that you're throwing. That you're putting the nerve in a tension test while you're throwing, or maybe the nerve jumps out of that little cubital tunnel while you throw. The other things to consider are cervical issues, Tommy John related conditions where you might have a UCL rupture or tear. Those can kind of tension that nerve a bit more than it should, and you may not be having a ton of pain because sometimes we have asymptomatic issues with ligamentous injuries and stuff like that, but you may be starting to feel nerve tensioning and zinging down into the fingers, which may be a sign that your UCL is compromised. And the other thing to consider is thoracic outlet syndrome, which is very popular nowadays, but probably doesn't account for as many nerve issues as it's been attributed to lately. It's become kind of a fad to diagnose thoracic outlet syndrome, and it's a very rare condition, especially in high school, college age athletes, things like that. Sometimes in our professional athletes we'll see it, but it's usually after a long period of time and depression on one side that's compressing it between the clavicle and the first rib, and that's not something we see all the time. And a lot of times that will have different symptoms than true ulnar nerve problems. And if we're seeing only ulnar nerve distribution issues, we have to look elsewhere and we have to rule things out before we're going to kind of go towards the thoracic outlet syndrome route. And a therapist is actually going to sequentially tension or slack portions of the ulnar nerve to try to figure out where is this coming from. And if it's only happening during the throw, it's sometimes more difficult to diagnose because you don't know, is it gapping of the joint that's causing it? Are you putting it in a provocative position, or is the nerve only subluxing under those high loads? So there's a lot of things to consider. The first one's always, okay, let's rule out the cervical spine. Now, what we'll do a lot of times is we'll actually try to compress the nerve root on that side and then try to tension it. And the tension is really going to be more of a generalized test that's going to tell us if there's an irritation of the nerve root or even of the nerve itself. So we can tension the nerve through bringing the arm up just above 90 degrees, bringing the elbow back, extending the wrist this way. And if you can tolerate this position, and this isn't reproducing your symptoms, you start to slowly bend your head to the other side and you feel it, you've just tensioned the nerve and you've repeated the symptoms, then we've got a problem with tensioning, or the nerve is at least irritated and maybe inflamed. If this doesn't do it, then I can look this way too, and that can tension it a bit more. And if I have the problem there, tension is provoking it. Now, if I'm here and I do this would slacken the nerve a little bit. If I feel it there, I'm compressing the nerve roots. And so I'm thinking more that maybe the problem is coming up here from the neck because of a compression issue. But there's a lot of things that are going on here, and there's a lot of things that a therapist would do in the clinical setting to try to evaluate this. These are just a couple things to consider on your own. It may not be a true nerve issue, it may be, but the first thing we always try to rule out is the cervical spine, because if the nerve is compressed up here, you will have symptoms all the way down its pathway potentially. So if I don't feel it with compression and I feel it with tension. All right, now I'm saying, okay, maybe it's still a cervical issue, but maybe it's here, maybe it's here. And in a therapy setting or a doctor's office, they'll test the ulnar collateral ligament. If that provokes it, then maybe that we have something going on with the UCL, or if we feel that there's laxity here where the joint moves too much and gaps too much, maybe there's a problem with the UCL that's tensioning that nerve on the inside, because when the UCL is compromised, you gap the inside like that. If I had a band going across here, you would see that that would stretch that band some. So sometimes that's what we actually see. And then after we've done that, we would try it with an elevated shoulder or a depressed shoulder. If we feel it with an elevated shoulder here, we're starting to think, and the cervical spine's in a good position, we're starting to think maybe it's coming down here from the elbow and there's some sort of entrapment or a tensioning issue. And maybe it's coming down from the elbow region or further down. And if I depress the shoulder, then maybe I'm actually having a thoracic outlet syndrome, or maybe just more tension on the nerve that's causing the problem. So there's always a lot of things that we're thinking about, and a lot of times diagnostic imaging like ultrasound, stressed ultrasound, sometimes those are the best thing, and sometimes you can't necessarily narrow it down, and you never really know what's going on exactly until you're inside the elbow itself. But ruling out the cervical spine before you ever get an ulnar nerve transposition or something like that through a medical professional is going to be the most important component. And then, I want to talk a little bit about flossing the nerve, which is a gliding of the nerve proximally and distally, because that's something I see online. And if you've addressed the scar tissue, done some massage, maybe there's some Graston instrument-assisted soft tissue mobilization the therapist did, or maybe they did some scar manipulation techniques to try to get the scar moving properly if you've had a surgery similar to mine, or assessing some soft tissue restrictions, moving that around. If those don't work, my last line of defense or my last application of exercise is a lot of times nerve flossing to see if that'll help to try to glide the nerve back and forth through its pathway. And kind of the idea there is you'll put the nerve where it's somewhat tensioned and then tension it distally and slacken it proximally. So I'd slacken it up by the spinal cord and tension it down towards the hand, and then do the opposite. So the nerve is kind of doing this back and forth. And sometimes that has success. Unfortunately, a lot of times it doesn't. You got to think, if you've actually had an ulnar nerve transposition, the way that the nerve moves and the dynamics of the nerve, the biomechanics of how the nerve slides and glides are going to be altered. So it's on the front of the joint now, so flexion isn't going to tension it, whereas if it's on the back of the joint and I flex, it's going to tension the nerve more. On the front of the joint now, up here, I'm going to actually have to extend it to tension the nerve and come back this way, similar to some of the other nerve tension tests. But basically what you would do for ulnar nerve flossing is I'd bring the arm up here above 90, back a little bit, and I'm going to use wrist movement and cervical spine movement to try to pull the nerve one way and then pull it the other way. So if I want to pull the nerve up towards the spinal cord or towards the cervical spine, I'll flex here and side bend away. If I want to do the opposite, I come there. So now the nerve is tensioned more here and slackened more here. Now the nerve is slackened more here and tensioned more here, which can cause a little relative gliding. And this is one way to do it. If I compress something, some sort of soft tissue, I can cause more excursion, but I'm also causing more friction. So in somebody that's got an irritated ulnar nerve, you got to be careful with what you do, because more friction in the nerve can exacerbate it. Sometimes just taking some downtime, taking some time off, can allow the nerve to calm down, inflammation to get out of the area, and you can go back to doing what you're doing. And a lot of times altering the way that you throw, improving the sequencing of your throw, can reduce tension on the ulnar nerve or prevent it from subluxing in the way that it was before. And I actually just had an athlete probably in February that was having some ulnar nerve problems, and it was shooting down in his hand. His elbow was numb for like 30 minutes after throwing the first time. Tested his UCL, it felt fine. And you know, we kind of looked through some different things, and I watched him throw, and he was dropping his arm back here, and he was side bending this way. And so what is he doing? He's tensioning his ulnar nerve just the same way that I did here. And so we got him more upright in his posture. We got him here instead of there with the ball where he would come out and around. And now the ulnar nerve issues were gone, and he no longer had the problem. He was all happy, and he went back and played. So sometimes there's biomechanical things in the throw we have to improve to get them out of the position that caused that. But I would say before you start just applying random nerve flossing techniques, have your elbow looked at, have your cervical spine evaluated, have your shoulder girdle assessed. And a lot of times this isn't the problem, but you know, you just want to rule things out before you go into a surgical protocol or start applying things that could potentially aggravate the nerve that's already a little bit aggravated. So hope you guys found this video informative, more of a discussional video, thinking video and things like that, less practical application, but I hope it helps some people out there that are going through this sort of thing.